Now I'm gonna do a quick swap, so hang in there 1 second. Because as I do this, it's gonna hop to my other screen and I'd actually like to be able to see you. So let's do this. How does that work for everybody? Are you still seeing the DHHS?
Yep.
You can see my clicker moving, whatever that's
Yes.
called, a mouse. There you go. All right, so here we go. So I am presenting this information because it is part of a mandatory requirement of the Preventive Health and Health Services Block Grant, which we call PSB. No, we don't call that actually anything, but it's PHHS BG. And so you'll see that if it's thrown in there throughout, that's what it is referring to. So we're required to have at least two advisory council meetings. One of the reasons that we disabled or disbanded, I guess, the FISC group was because it made more sense as we're looking at state health improvement planning, and this is really thinking about preventive health and health services, made sense to use this advisory council also as the PHHS Block Grant Advisory Council. So the role of this committee is I call it council committee, they're, to me, exchangeable. But we're looking to you all to understand kind of what's going on in the PHHS block grant and then make recommendations to us. And so it's trying to figure out, are we making sure that we have public health services assessments available, activities that we're conducting, allocation of funding and services, coordination of activities, and data collection and reporting. So this is really the block grant this PHHS block grant is utilized for those foundational activities. It's not to do a new initiative. Oftentimes it's really to invest in one of those essential public health services or several in the case of New Hampshire. And so today's purpose is really to review the division's work plan for the current year. So I'm going to really talk to you about what we've allocated to which activities and then what progress they've made on those activities and then the funding associated with that. And then thinking about and potentially revisions for future program priorities and activities. Any questions before I go on to the next slide? And I won't be able to see if there are questions because I'm sharing screen. So Joe, go ahead and shout out, or anybody else in that room, in case you have any questions. So overall, this is a $2.2 million grant. Certainly modest compared to what happened in the COVID times, but it's definitely an essential part of our foundational capabilities. So we spent about half of that grant on personnel. There is an overtime line which allows us to have the 24/7 access to our public health nurses. There are a lot of different contracts, and I will go through what each of those contracts are going toward and how much they're for. There's lab supplies that we need in order to do some of the testing. So that includes reagents, etc. There's office supplies, software, equipment that is needed. Travel, a minimal amount of travel in the past couple of years, but this is one of those things that if there is an annual meeting or something like that, that somebody is needed to go to, this funding can be used for that. There's a library subscription that allows us free of charge access to the most up-to-date evidence-based public health articles. So that's something that I think really goes under-recognized in this grant, but actually allows us to just click through and get to something like the American Journal of Public Health. So there's allocated costs, which includes personnel also, because we do have some limitations on how personnel are charged to this grant. And then, so it's the 2.02 is the total award. There is one part that's a sex offense set aside that must go to sexual assault prevention activities.
Alia, is the allocated cost just for personnel, or are there other things under that line?
No, so that goes for everything from our contracts and procurement process services to our administrative costs such as cubicle space, etc. So depending on which of the personnel are funded under this grant, they need their cubicle space allocated in that percentage, those kinds of things. So it's really that indirect cost rate is how the majority
Okay.
of organizations would probably think of those costs.
Okay. All right, thank you.
So this is how it splits up. Our data portal has $44,000 out of that allocation. BRFSS for adults is 133,000, and that's one of the areas that has gone up in recent years due to cost increases overall. The public health advisory councils right now have $195,000 of this funding, split across the 13. The SHA-SHIP facilitation has the $80,000 allocated toward it. Injury Prevention Center for this year was decreased to $19,465. Sexual violence prevention, again, that's a non-negotiable total. Oral health clinics, I'll go into in more detail. Our cancer registry, which is, again, some of those foundational capabilities that you need to have. And then we have contractual staff that are part-time staff that are helping out with some of the activities, particularly with accreditation. Public health library, as I said before, and then we actually have a student fellow stipend that we were able to offer, which was exciting, and the first time we've done that. So
I should know this, Alia, but what is,
hope that you just went mute. Can you say it again? I think that
yeah,
was.
I should know what BRFSS is, but
Oh.
I have no idea now.
You shouldn't, and I should have
Okay.
said it. So it's behavioral risk factor surveillance system. So there is a child version and there's an adult version, and we call it BRFS, which is so lovely a name. But those surveys are distributed yearly. Then we try to get the behaviors, risk behaviors that people have across the state of New Hampshire to really understand what kinds of behavior risk activities do we need to be targeting. So anything from drug use to using something like tobacco products, and kind of the list goes on and on. So there's all sorts of behaviors that we know put people at social risk and physical risk inside of those questions, but they're really, it's a person calling and asking these questions. And so because overall costs have gone up across the last few years, we've really seen an increase in the cost to administer each survey, whether that's the adult or the child, but this one is particular to the adult.
And who's administering the test? I mean, the survey?
So we have a contractor that does that work
Okay.
for us, and then the data comes back to our data portal group that I am, Bureau of Public Health Statistics and Informatics.
Thank you.
Yeah, no problem. So this is, and I will now remember to do each of these acronyms, and I'm sorry that there are acronyms on the slides. I was trying to get a lot into a small area, but this is the Bureau of Infectious Disease Control. It's the group that really looks at the surveillance of different infectious diseases across the state of New Hampshire. They do investigations, so if there is an outbreak, they try to figure out where that source is. So you would have seen and or heard about their activities during COVID-19 outbreaks, during the Legionella outbreaks, Legionnaire's disease outbreaks, those kinds of things. So they also work on control and prevention activities. So as soon as we have something like a GI outbreak, they will initiate the investigation for that and then try to ensure that there's no source, for instance, in a specific restaurant, or they've eaten the same food that then they would either feed up to a different surveillance system. So when you see something like, oh, cinnamon is causing a bunch of lead poisoning, which I know isn't included in this particular thing, but those kinds of activities, that's when we start to see, oh, there's a trend across the country, or there's a trend across the state of New Hampshire. We really need to shut down this restaurant, or we need to go to the source of, for instance, the factory that creates cinnamon and make sure that there's nothing else that is contributing to this problem there. So it really is that, again, foundational capabilities. This particular grant focuses on GI or gastrointestinal outbreaks. So like I said, like something like a food safety concern. There's hepatitis A cases and pertussis cases, as well as tuberculosis. So just up between October 1st, 2023 and January, we already had 2 GI outbreaks that were investigated on the day of the report, which is a turnaround time that's to meet a certain standard. There were 48 potential Hep A cases that were investigated, and none were confirmed to go on to be Hep A cases, which is great because then we can prevent the transmission. 12 potential pertussis cases, and they had 7 different contacts that were all given treatment within this certain window that allowed that to be no secondary cases. And that's a huge reduction in how that particular disease can spread. And same thing with tuberculosis or TB. So there were 30 TB cases that were investigated. There were 14 reports of suspected cases. 4 actually did become confirmed TB cases. So they actually, from that point, receive case management services through our Bureau of Infectious Disease Control. So that keeps it from going from that person to another person. And there's a certain time frame that particular drugs need to be taken in order to actually reduce or omit TB from that person's system. And then 16 B1s were notified of during reporting and have also gotten case management services. So go ahead.
Alia, did you say that these are the only diseases that are investigated under this funding? So there is
Yes.
funding for different types of infectious diseases? Okay.
Yes, yeah. So
Okay.
while this is focused really on GI, Hep A,
Okay.
pertussis, and TB, we have other areas of funding. So there's also secondary TB funding, but doesn't cover enough of the kind of time frame concerns that we have. The 24-hour availability of our nurse line is covered under this funding amount. So there is sometimes different pairing or matching of different funds to be able to make the personnel costs work, et cetera. But this is for these 4 areas, some of the foundational funding sources that work to fund some of our nurses. All right. Our data portal, for those of you who don't know or haven't used it, formerly known as Wisdom, is our public facing dashboards. So they have $44,000 that's contracted to be able to create new dashboards. So there's some exciting potential ship work in the future that I will be excited to share with you at some point. But this really covers some of the updating of dashboards that we have data for. And so a little bit boring in concept, but really is how you get that public facing availability of data that you can access, download, and understand trends. This is that behavioral risk factor surveillance system information that we were talking about before. So it's $133,000 that's contracted out. But they conduct up to 550 interviews per month. So between October 1st and January 2023, that should say January 2024, they completed just under 2,500 interviews. And again, this leads to the data that you would be able to understand about what are some of the changes within behavioral risk factors. So, how are we looking for vaping across adults? Are there more adults engaging in risky sexual behaviors, et cetera, those kinds of things. The idea is that we surveil so we can introduce new mitigation measures. So SHA-SHIP funding has reduced since last year, and this is partially because I have been moved off as the person's salary who impacted this a lot. So we're trying to really think about how do we fund people best. So the total funding is $149,197. So that's the creation of a SHA and a SHIP and the access to the public health digital library. And so the goal was to really choose those priorities for implementation and the priority health outcomes that are going to be implemented. And we are pursuing a component of what's called public health accreditation, or also known as PHAB or FAB. And that total funding is $272,213. And that's really the readiness assessment. So that is estimated to be completed somewhere around February 1st, 2025. That RFA has been posted. The vendor has not yet been chosen, but that will be our readiness assessment. And these are public health advisory councils. So there's $195,000 spread across the 13 different regions. And that's for the CHA and CHIP development. So the goal for this year was to align their CHAs and CHIPs with the SHA and the SHIP, or at least the CHIP with the SHIP. And all regional public health networks have really done an amazing job trying to just meet the continuous kind of changes over the last couple of years of this alignment. So they've all created those CHIPs and work plans to be able to do that.
Oh, yeah, we have about just a couple minutes left. I don't know if we need to put this to next month too, or.
No, I think we'll probably get there. I think we're unfortunately can't see the slide number that are left, but I'm pretty sure this is closer to the end than the beginning. So, our health officer liaison program works with our health officers whom you heard from in a couple months ago, but it's really about maintaining the education level, maintaining health officer appointments for any vacant positions, and then maintaining the contact information for all of those health officers. So there were 65 different technical assistance activities that were delivered by our health officer liaison program. 199 appointments were maintained. So it was keeping it to a 9% vacancy rate. The department does help to appoint those new members and get them all up to speed on education. So food protection is really thinking about how do we make sure that we analyze inspection reports and then ensure that we offer repeat offenders some additional education and help and support to make sure that they stop having violations. Because the point is not to get everybody in trouble. It's actually just to keep everybody safe that is eating at those retail food establishments. So the total funding there is $53,518. Cancer registry, as I had said before, that contract is $119,000, but there's some other costs involved in that. And it's really just making sure that we have completed our registry or making sure that the data is in to this database to make sure that we, by 4 months, have completed that entry into that registry. Our oral health programs receive a larger chunk of the funding. It's $358,000. And that's really our school-based sealant programs, as well as dental screening referrals for diabetics. So we're trying to decrease tooth decay in our children, and then referring up to 61% of diabetics to a dental screening because it's difficult to get those both done. It's also easier to do a warm handoff for somebody into those additional services, and diabetics are at disproportionate risk for periodontal disease. So the contract delayed the start of our sealant programs, but that is going through GNC hopefully soon. And then 28% of our diabetics were referred for screening. Sexual violence prevention, again, is one of those foundational activities that we have to complete. There's this carve out. So it's ensuring that there are some sexual violence education programs. We've maintained 12 member programs and delivered that community education through those programs. Injury prevention is focused on suicide rates and reducing suicide rates and increasing bike safety education. And I will provide these slides for Joe to send out so that you can look through these at your leisure as I kind of fly through the rest of it. Yeah. And this is the last one. This is the public health lab. So in addition to our Bureau of Infectious Disease Control, where they are understanding that the sample is positive and then reaching out to do an investigation and prevention and treatment of the folks that test positive, we also need to make sure that people are getting the actual testing for tuberculosis or TB. So they do that foundational testing. They do rabies foundational testing, and then paralytic shellfish poisoning testing. So they have implemented some new technology over the last couple of years for rabies and tuberculosis testing to make it a faster test result. And then paralytic shellfish poisoning as well. They have been able to get results for each of the TB tests within 48 hours or 2 days, which is important because of how quickly that spreads. And then there were 185 rabies tests done, which was only a 90.8% accomplishment of resulting those within 24 hours, but it was partially because they took on additional volume from Massachusetts, because Massachusetts was having a public health lab renovation. So that was really something that added to their volume of work. And then 84% of shellfish were tested within 24 hours. But one of the things that needed was our fume hood replacement in order to safely do that testing. So we were able to, as a result of movement of staff salaries, et cetera, support the purchase of the new hood so that they can safely do that work. So the lab also got to experience a flood in the last year or so. So they've really pushed through a lot of additional challenges and have gotten a ton done. And that is it.
Thanks, Alia. So
Mhm.
Greg had a question about the ability to disaggregate data in the BRFSS for demographics. Can you answer that question? And then we'll shift over.
So I think it depends on whether you're talking about the childhood BRFSS, the adult BRFSS, and or the year. So more, I can certainly speak to that more if you want to shoot me an email and get an official answer from our BIPC group.
Thanks. So what we can do, because we went through that quickly, is we can send out the slides and add discussion time for at the next meeting. Ed, do you want to ask a question before we shift? Or
just two quick things on oral health is, I apologize for being snarky, but I take offense to people being referred to as diabetics. I have a total hip. I don't know what you would call me to offend me. Though I did go to crippled children's center as a small child, which has become passe. It's people with diabetes. I even correct people with diabetes and stop referring to themselves as health condition. The other is when I look at the screening, that's nice, but it doesn't answer the so what question. I think the so what question is when you look at the oral health condition of someone who has diabetes, what is the condition, and then comparing it to the hemoglobin A1C values, because perhaps the solution of getting someone's diabetes in control rather than being a patient, which is what American medicine does. When all else fails, idiopathic, then the patient, welcome to American medicine, economic help. What do we do about that? So if they have a strep mutans infection or chronic inflammatory disease process or cytokine storm, anybody wants to put their head on their shoulders and the mouth back in the head of American medicine, but I can always dream for the little bit of time I have left in life. Any Snooki Friday.
Thanks, Ed. So Greg, I can't actually repeat all of that,
Nor would I ask you to because
but
it won't matter anyways.
But I think the crux of the question is, how do we get to a place in which when we have screenings, we have the resources necessary to do something about what we screen and
I
find?
mean, American to do the right thing.
Well, on that note, it's a very nice segue into the next part of this conversation.
Rhetorical, there is no right.
That's fine. So again, we'll send out these slides. I think, and all, you can correct me if I'm wrong, part of what we want is this group to react to the information that's been presented. So we'll offer some reflection time, in the next meeting. But I'm going to just turn the floor over. Sometimes I would show you all what we put in the Sean ship around this issue, but I would like to just jump us right into the presentation. I also am trying to figure out the easiest way for us to see our presenters and our material at the same.
Can you go to view? And then do side by side speaker. or
Okay,
side
and
by
we're
side
gonna-
gallery.
Perfect.
Laura's going to start, so you can pin her.
If we pin the gallery, we're all right. Thank you, Katie. Thank you. Okay.
Spotlight us both.
Yeah, so Laura and Rebecca Sky are, thank you for taking the time to join us today. I'm gonna just hand the floor over, let you all introduce yourselves. Because if I try to introduce Laura, I'll say things she won't want me to say, so.
Fair enough. So I'm Laura Davey. I am currently the interim director of the Institute for Health Policy and Practice. And also I co-direct the Center on Aging Community Living, which is a collaboration with the Institute for Health Policy and Practice and the Institute on Disability at UNH. And I'll turn it over to Rebecca to say hello.
Hi, so my name is Rebecca Sky. I am the executive director for the New Hampshire State Commission on Aging, which is a wonderful group of 26 people. There are there's one state senator, 2 state reps, 8 state agencies that are represented on the commission, and 13 people who have been appointed by the governor. It was established during the 2019 legislative session, and we are, I guess, 3 to 4 years in, and we are hopefully beginning to have an impact. We're probably further along than beginning to have an impact, I'd like to say, but I'm excited for the opportunity to talk with all of you. So thank you.
Awesome. All right. If I could figure out the slide deck. So Joe and Polly, I would appreciate both of you kind of prepping Rebecca and I for this. And Wendy Altman was the Bureau Chief of Elderly and Adult Services at the Department of Health and Human Services, was trying to make it. It just it didn't work out in the end. But we know we want to kind of understand the social service infrastructure, especially as it pertains to older adults, identifying alignment between the SHIP and some other plans, described some of the unmet need, and then really hope to have some time for discussion about how we can, leverage and collaborate between kind of the aging services network and the public health networks or system. I want to say systems. That's possible. So I get to kick off with an overview of how the social service system for older adults is is established or, kind of the government side of it, right? And it's really a system, I want to say, for all payers and all populations. So the vision of this system, and I apologize also because I did, had NWD up there. It's actually called the No Wrong Door System of Access for Long-Term Supports and Services. So with that, I think it's just important to understand the state's vision and even the federal government's vision as we strive to have age-friendly communities, as we strive to improve the ability for older adults to age in the communities. Wendy and I have been engaged in this state university partnership back and forth, or DHHS UNH partnership around the Aging and Disability Resource Center model since 2003, me since 2006. Under a no wrong door system of access to long-term supports and services, I'll also say, when I use the words long-term supports and services, I mean, again, all payers, all populations, formal, informal supports and services. Many people, for reason, see it as just Medicaid or public programs, but I do use it in my vernacular very broadly because as we know, it's all of that when we think of person-centered planning, it's all of those things coming together to support older adults that's needed. So with that, I can go on for 20, a long time about the no wrong door system of access, because this is what I love to do. But we wanted to mention that there's 4 key elements. So there's person-centered counseling in the system, there's streamlined eligibility, there's outreach to key partners, and then there's this governance piece. For a good decade plus, New Hampshire has done really well on implementing 3 out of the 4 key pieces. I say that knowing that, yes, there are many gaps in achieving the vision of all payers and all populations, but we do have aging and disability resource centers in every county. We do have the New Hampshire Care Path system, talk about a little bit. Person-centered counseling is a key part of the delivery of care, and have been working and training folks in that and working on the systems for decades. Streamlined eligibility, as my other former boss used to say, is a hardy perennial. We need to continue to do more around that, and outreach. There's a great process within New Hampshire Care Path around outreach and engagement. But governance was one that wasn't as strong in New Hampshire. And so we've been able to most recently work with all of these folks on this screen. New Hampshire Care Path Partners, which you see down in the bottom right-hand corner, DHHS units, and stakeholder groups that include both organizations and individuals with lived experience. And why I wanted to point this out and have this slide, and Rebecca said, "Are you sure? Are you sure, Laura?" I said, "Yes, I'm sure, Rebecca." Because the goal of this governing system is to coordinate the ongoing development, implementation, financing, evaluation, and continual improvement of the state's no wrong door system of access to long-term supports and services. And again, even though it says the state, the system LTSS, it is in the true vision, all payers, all populations. So I think it's one of those things as you're thinking about those intersections, how do you leverage this? How do we leverage? And maybe it's we add public health to that DHHS governing body, as I'm sitting here thinking and pondering. I didn't think of that prior. I know this is a difficult visual to see. And in some ways that aligns with the issue, right? It is really difficult to know how to access supports and services in New Hampshire. And in 2015, New Hampshire established what I've been referring to as New Hampshire Care Path. It was done under the balancing incentive funding, some might remember. And it was to brand this no wrong door system of access to supports and services. To say that people didn't have to go through all these websites or have to know all these numbers or know all these locations, that with this New Hampshire Care Path, they could call one number, one website, and get to where they needed to go. grant ended, marketing ended. It's not as robust as it needs to be and should be in New Hampshire. And you all know, and we know public health and aging services, there's a lot of alignment, especially around the prevention side that we need to focus on. Is state government doesn't want to, federal government, they don't want to work on prevention, right? If you market New Hampshire Care Path, if you market these things, people might find services that cost us money. So that wasn't in my notes. Probably should keep down that part, but so we've done this assessment, right, of access to long-term supports and services in New Hampshire. And it has included this, map. It's included a worse looking map of all the referral, how these entities talk to each other. That's a web. And we also interviewed individuals and caregivers, and we reviewed existing reports. Wanted to also share, and I think this might have been in another previous presentation to you all, is, again, New Hampshire supports services and supports infrastructure. It includes all of these social service-based entities that do help support individuals to live longer, hopefully independently, in the community of their choice, in the environment of their choice. A few things that are missing: housing, we haven't added that in here, and providers of personal care services, or all those home modification programs that are needed. So again, another visual of like, what does this whole system look like, and how do those pieces, how can we bring those pieces better, enhance them to serve more folks? So I mentioned this current assessment that's going on around access to supports and services. We're still finalizing all the key themes, but wanted to share that a few of what we've heard is that long-term supports and services in New Hampshire, we've heard that they're only for people who have low financial resources. So it's for someone else. And that's one of those conversations we need to stop, because it is about planning and prevention and being able to bring in all those formal and informal supports, so you don't have to go to, somebody get to the point where you need financial resources. People don't know where to go, low awareness of the different partners. And 54% of people who were surveyed on the New Hampshire State Plan on Aging didn't know what ServiceLink was, our ServiceLink Aging and Disability Resource Center, which within the No Wrong Door system of access is the full access point. So they really have a large role to play with our other partners of the area agencies for developmental disabilities, our community mental health centers, and our district offices, and a lot more. Language translation barriers and discrimination deepen the barriers to access. We really are looking at caregiving. There's a strong focus on caregiving in this project and across the nation. And one of the major issues is a delayed identification as a caregiver. People don't see themselves as that until it's later, and I would often say, and then if somebody does come to the decision of putting somebody in a facility, then they think their caregiving is over, which it never is, right? It continues. Another thing that we've noticed and took out of this assessment is, even if you have high education skills and the ability to research things on your own, it's difficult to find that information. It's difficult to, difficult means that communication, marketing, and information sharing needs to be easy to understand and broadly shared. And again, these are so similar to all the things that the public health system grapples with every day. On the intake and assessment side, there's too many applications, eligibility takes too long, and it's just frustrating and exhausting for people who are really struggling. So mentioned, there is this New Hampshire Care Path, which is this vision of the system. It has a website, which we've included in the resources at the end. There's frequently asked questions, online trainings, understanding waivers, but it's also understanding veteran services. It's also understanding caregiver services, or a good bazillion different things. ServiceLink has a public searchable site for services. And it's really improved. Back when I was more deep in it 10 years ago, I was like, oh, that's not very friendly. It's actually much better now than it has been. And I've included that link at the end. And again, one of those things, how do we integrate some of those services, searching for services on the public health side that, you know, vaccines, what's this website doing and how is it, you know, is that information similar or can we add stuff to on either side? And then Wellness Link, it's the vision of the Partnership for Public Health on this intersection of public health and aging. And it's coming to fruition through what we've branded as Wellness Link. We had some COVID money around vaccine education and awareness. We're able to work with the folks at Carissa Elphick up there. And she's been able to take that and also think a lot about loneliness. When we think about loneliness, aging and public health, loneliness is similar to, you know, smoking. Can't remember the exact number of packs of cigarette a day, but it's very impactful on our health and well-being. Am I going to do these, Rebecca? The system of care? Yeah. All right. So Wendy couldn't be here as we mentioned, but there were two pieces from that Wendy wanted to talk and make sure you all knew about, again, kind of to help build on how do we enhance the services in our communities for older adults. One is, and Martha can talk to this much better than I, Martha McLeod, but and the Alliance for Healthy Aging and the work that they've done is incredible to get this House Bill 2 funding called the System of Care for Healthy Aging. So really want to thank them, all of them, for the hard work. It's providing much needed core funding, not grant funding, to the system of access to enhance it. And on this slide and the next one are those goals and objectives. I don't want to spend a ton of time, and Martha could answer, as I said, answer a bunch of questions better than I, but it is to improve access and timely delivery of supports and services and ensure individuals have a meaningful range of options. Mm-hmm. And I'll add my little side note, meaningful to them, not what I deem meaningful or the system deems meaningful to individuals. It's also to help reduce the cost to the system, especially the Medicaid system, by expanding home and community-based services.
Oh, can I interject?
Yeah.
Oh, was it on that one? Oh, no, it's this next one. Never mind. Go for it.
Can I ask a question on the last one, which was, Laura, on the slide that says reduce cost of long-term care versus community-based services? My concern is, do we really have a sense of, is it equal? Is it less? Because to me, doing community-based care, it feels more expensive than ever. And I'm not sure that we haven't reached a tipping point where potentially it's equal, right?
Yeah, thank you, Maggie. I think that's it's been a debate for as long as I've been in this, which is almost 20 years now. That I think that most of historically the research has shown that if we deliver services in the home from the medical standpoint, from the public standpoint, it is less costly overall than nursing home level of care, right? That said, your point about where the system is now with our workforce, with our whole housing issues and home modifications needed. I haven't seen anything come out more recently around that, but it's always, I think overall, it still is going to be cost the system less this, and I'll just keep saying the system less, because we know the burden that our informal caregivers provide in keeping somebody home. But yeah, it's a great question that we need to keep our eye on.
If I could echo Maggie on that, this is Becky Bryant from Lakes Region Community Services, and we provide services, obviously, for those that know us, in the DD system as well as in the elder care community-based system. And I think the concern for me is that in the DD system, we've always been compared. They compare our average cost in our system to what is set as the institutional level of care cost and compare that. And it's just a slippery slope right now. I agree with Maggie. The costs of community-based aren't really being captured when we don't even have enough staff to provide the services. So we don't have any true picture of community-based cost. And what is the cost of leaving elders underserved or unserved and then hitting the medical and long-term care system sooner than they should? So that's a whole conversation for itself, but one that, I mean, we feel very passionately about as we literally turn away clients every single day of the week, all day long in the elder system, and just are so desperately knowing that we could provide significant impact to our community if we had the staff to do the work. So I'll just add that.
Yes.
And Laura, this is Bobby, so I have a question just to add on to that because, and I think you're right, so we do need to capture that kind of data. So anecdotally, and I do think that public health should be somewhere in there, as far as a partner. You know, we have community health workers that have been going into the community and following up, like after, someone is released from the hospital. And so, we've had a lot of different types of situations and scenarios, which we don't have time to like discuss here, but I mean, the workforce capacity is one. I was wondering, Laura, how you would collect that data that we're talking about is needed as far as how do we determine what the true home-based care costs are. And, you know, when our community health workers go in and help, and we've even started collecting data from the assist that the fire department goes in when some people fall or they can't get up, they'll call the fire department. So our health department is now collecting that data. And then when we go in, what we find is the homes are sometimes inhabitable for folks. And then there's no place for them to go if they get removed from the home. You can't get them into a nursing home because then there's that long process with the paperwork that takes a long time. We've placed people into motels, which is not ideal, which also is not safe. So there's a lot. So I hope we can have a bigger conversation about this because we definitely need to determine what we need to do to improve the system of care for healthy aging. It's our fastest growing population. We are seeing a lot of things in the community. I've been going to do regional meetings with our FEP coordinator. And so we've been meeting with the health officers and the emergency management directors. We've done 4 towns already, and we hear lots of issues and stories. And part of them is our response from the Bureau. And Laura, I know that you and Rebecca are the messengers, so please don't take this personally. But we need a lot of work done there. Usually what I get is a response of, we don't have any funds and we don't have any staff. And then my question is, then what do you do? How can you help us? And then how can the community actually be more responsive to the needs that we're seeing if we don't have the data, right? So that's a longer conversation. We should meet, Laura.
I'd love to. And I would say one of the goals of the system of care, and it's on here, is to get the, you know, this infusion of money is going to help. It's not going to solve,
Right.
but it is going to help. And there's accountability and performance metrics. So on the state side, there's going to be, you know, there's this influx to help with performance measures to capture that. And, you know, so that's there. And we do need to come together better to make that, to collect that information and to understand it as a state. So I'm 100%.
I'm going to say that for advocates, that was the major push behind the system of care legislation that was passed last year was getting the state more accountable to having an adequate system of care and measuring adequacy and making sure there's going to be a public dashboard by the end of it all that we all can look at and we can and improve upon, because I'm sure that first round of metrics won't be the metrics that we actually need. Bobby, I also just want to follow up on the lift assists in the communities. I would love to get some of your data because there is a bill before the legislature this year that would provide Medicaid reimbursement for non-transport visits. which I believe Lift Assist would come under. So getting, as you said, data is important to making for just policymakers to be able to make good decisions. So let's connect.
Yeah, so that system of care, we hope is a good influx. I've already seen some in terms of hiring and I've seen some good signs. Again, not gonna, but hopefully some better responses and ability to come to the table and be more collaborative. The other piece that we wanted to mention in terms of looking at and understanding kind of alignments with public health system is the state plan on aging. It's a roadmap to ensure advancement of the state's efforts in supporting and serving older adults. Lots of objectives. You can see the 4 here. Age-friendly communities, rights and safety, active and healthy, a lot around okay, here's a better one. So some of the themed intersections with public health that we all need to be aware of is falls prevention, emergency preparedness and response, and food and nutrition, public awareness campaigns for Alzheimer's disease and related dementias. And then there's some continued work with chronic disease self-management programs. So when we think about what's in that state plan, what's in this state health improvement plan, how do we leverage these things moving forward? And I snuck in one more slide, Rebecca, because she gave me final approval for the slide deck. So, but this kind of gets to what the problem is, and it's one of my favorites. And I had a student help redo it, but if you look at federal funding, right? So this is Department of Defense, Centers for Medicare and Medicaid Services, and then you look at Older Americans Act. So Older Americans Act are the funding streams that provide transportation, caregiving supports, adult protective services. I'm missing a lot, transportation.
Nutrition,
Nutrition.
Office of Long-Term Care Ombudsman, service links, information referral, the list just goes on and on. The weatherization programs, yeah.
So Medicare and Medicaid were passed by the federal government in the same year as the Older Americans Act. And yet, for now, way too long, though, CMS especially, our medical model drives our system. And this is that alignment with aging services and public health. That medical model still drives us. And we're not seeing the increase on, you can barely even see the Older Americans Act dollar spending on this graph. You can tell my emotion.
Yeah, that slide gets my approval, 100%. Polly had asked that I just take a step back before I jump into this piece and just talk a little bit, really defining what long-term services and supports are. Laura did touch on it, but it is supports that help individuals with their personal care, everything from nutrition, bathing and dressing, to daily living needs like housework, meal preparation, grocery shopping, and some basic medical needs. These services are provided in people's homes. They're provided in adult day settings, and it's also provided in long-term care facilities. So that's a quick snapshot when I go about defining long-term services and supports. So Laura and I both had like 20-minute presentations here, so we'll see what I can do in the time.
That's okay.
Okay. So you've just heard in detail about the systems of care for healthy aging and the wide range of work being done in aging services. And the question arises about how does this overlay with the work being done to date on the state health improvement assessment and plan, and what are the barriers and opportunities for action at the intersection? Laura did a great job of naming several as she was going along. I'm going to do a little bit more by taking it from the perspective of looking at the state health improvement plan and inserting some of these ideas into it. The state health improvement plan has the 4 domains. Specifically, you were looking for ways to expand resources that empower people to age healthfully and safely in their community of choice. Within the domains, this is listed under social connectedness. And what I'm going to suggest is that there are ways to weave this intention throughout all the domains in the state health improvement plan. So Not quite yet.
Oh, come on.
Oh, okay. See,
I was in
shoot.
anticipation.
Yeah. So,
Oh,
so in thinking about this, I reviewed the state health improvement assessment materials with a lens focused on older adults. And I love how you identify areas to explore more. So in the spirit of sharing, at the end of the slide deck, not for viewing now, but if on your own time later, if you want, I've added a few age lens musings in relation to the content that's in the state health, in the assessment piece that's available on your website. And before I dive in, I just do want to recognize that the huge amount of expertise in the room. You're a very aware group, and I don't believe that I will be uncovering any new ideas with my brainstorming. But I do know how helpful it is to have somebody with a micro focus on a particular topic to review work that has a broad reach. So that's my hope here. It's not to step on toes. It's really just to help expand thinking. So now the next slide. So with this in mind, I just want to reinforce the value of weaving the concerns of older adults throughout the state health improvement plan. The main case, of course, is that older people represent such a large and growing part of New Hampshire's population. According to the 2020 census, 19% of New Hampshire's population is 65 plus, and it's anticipated by 2030 that over 1/3 of New Hampshire's population will be 65 plus. If you look at the top graph, take note of the 80 to 84 range and the 85 plus, which is the green line, and the 80 to 84 is the blue dotted line. They both peak around 2045. The literature varies on how many of us will actually need long-term services and supports. One study says that of people who survive to age 85, 54% will need services and 34% will need nursing home care. The study goes on to say that older adults with limited lifetime earnings are more likely to develop serious long-term services supports needs than those with more earnings. This is certainly an equity issue. And when thinking about equity, we also need to think about be conscious to where older adults live in our state. The graph on the bottom right, it's not should not be surprising to any of you that the greatest number of older adults is where our population is most dense in the southern portion of the state, and per capita, Carroll County wins the prize, and with the northern and western counties having falling close behind. Next slide.
Yeah, I'm going to go to the next slide, and I'm going to say that the Healthy Aging Data Report is a great resource. It's being updated in 2024. So it was 2019, 2024. It's also included in the resources at the end, and we're going to be able to see some trend data. And it'd be great, like when that comes out, maybe to do a little 15 minutes on what that is seeing in alignment with how close is a grocery store to those 65 and older, how, a lot of those determinants of health.
So I'm mostly going to speak from what I know best, the perspective of the commission, but please note that there's many folks that are working on these issues. The Alliance for Healthy Aging actually was instrumental in establishing the commission. It's a collective impact effort. There's lots of work happening within their committees and as a coalition as a whole. And of course, the Bureau of Elderly and Adult Services is also is front and center to a lot of this work. So I don't like to do busy slides like this, but my point is that you can go back and read this later. And I wanted it as a reference for you, and I pulled this together pretty quickly. So those are all my caveats. So
and I told you you had to limit your slides.
Yeah, which I blew out that limit anyway. So here's a first look at the strategies listed by domain in the State Health Improvement Plan and aligned work that could be built upon. Expanding thinking on all three named strategies in this particular domain, the access to opportunity. Don't worry, I don't do that for all the domains. So the first strategy is to remove barriers limiting access to safe, affordable, disaster-resilient shelter. The Commission on Aging is very interested in housing stability and is advocating in the legislature to support this work. Laura already mentioned community action programs. They have weatherization programs and they manage rental assistance and homelessness outreach. They do a lot of fabulous work in this arena. Secure housing is tricky for people on fixed income. Just thinking about it, my husband just the other day was noting in the paper that property taxes are set to rise by 30% in Pembroke next year. Given the median property tax bill in New Hampshire of $6,100, that's an extra $150 a month. It's just, and just, adding to that, long-term services and supports, the Medicaid match is borne by counties, which is our property taxes at work. It's only the strain on our property tax system is only going to grow. Okay, the second sub-strategy is increasing housing stock that meets all accessibility needs. Bring on the age-ready housing. We are 100% in support of this, and there's many people working in this area. Another issue that you could expand this by also talking about expanding housing with supports. This is an issue that from the early days of the commission was brought up. We need more housing that has long-term services and supports that come along with it. But other supportive housing models, like those for mental health and for recovery housing, they need an overlay of long-term services and supports. I was just speaking the other day with Herb Carpenter, who's the executive director of Fellowship House, and he was saying that they have a progressive model where they move people from very supportive housing into more independent living, and they're having some of their older residents regress back into the more supported housing because of mobility issues and cognition issues. I see Kim has her hand raised. Do you want to throw in a comment before I move on?
Yes, thank you. It's so important that we understand that persons with intellectual and developmental disabilities are included in that long-term housing support, because behavioral health now tends to talk more about substance use issues. And over time in New Hampshire, there has been sort of some negative attitudes about congregate living for persons with developmental disabilities. And yet there's more safety in numbers. A lot of these ways that we're placing people in other people's homes, calling it adult foster care or home providers, is really just isolation and not that safety. But there are new models. There's some in Enfield, and there's one in Dover coming up under Our Place. And then you still have farmsteads in Hillsborough and a new one being built in Epping that show that congregate housing is a form of long-term housing support for persons with developmental disabilities that is sustainable, particularly with our workforce shortages, and affordable. So I would just like people who work on these issues to make sure that those populations are included with these other groups, because that's where the maximum benefit is in supportive housing for those groups, in my opinion. Thank you.
That's a great comment. Thank you so much for that. 100% in agreement. And so I guess, and under the issue of homelessness, I just, as an equity point, there's a lot of great data out there, but there's nothing that's really looking at the older adult population. At the March 2023 commission meeting, we had the executive director for Crossroads House come and speak with us in Portsmouth, and he reported a 36% growth in the 65 population in his shelter over the previous year. And he's not alone in this. I've also heard from folks in Manchester similarly. And the challenge is that these folks need long-term services supports, and shelters are not set up to do that. They only have so many lower bunk beds. Just so more data would be wonderful to get. I'm losing the audience. Oh my gosh.
We're recording you, Rebecca. That's why.
Okay.
Why we're recording you.
Okay, so moving quickly on, expand infrastructure and programs that promote financial independence and self-sufficiency. And one of the sub-bullets was strengthening access to information via reliable high-speed internet. I'm sure many of you are aware of New Hampshire's digital equity plan. There's a significant amount of funding. Laura talked about the long-term services and supports ServiceLink online website where you can access resources. There's a work to be done to improve the accessibility of that site, and this funding could support that. So definitely check out the funding available there to support that access to websites, improve access to websites. Increasing employment opportunities and offering a livable wage. it's a banner that the commission waves that we need to do more to develop intergeneral workplaces. I have some data about nationally job seekers age 55 plus who were long-term unemployed in September 2023 was approximately 27% compared to 19% of job seekers ages 16 to 54. That comes from AARP. And in 2021, the American Community Survey estimated that 27% of New Hampshire's 65 plus population worked in the previous 12 months. We really need to do a lot to make sure, take care of that ageism in the workplace that we know exists. Promote efforts to create centralized resource directories. Laura talked a lot about No Wrong Door. I'm not going to go further into that. I'm not going to give her a chance to add more here. Expand efforts to improve nutrition security and promote healthy dietary patterns. There is a bill before the New Hampshire legislature this year that would direct the DHHS to take on the SNAP Elderly Simplified application. It's a simple, it streamlines the process. It waives the recertification interview requirements and extends the certification period. It's also, I know folks at DHHS always want to do more, and it's a question of resources. This is one thing that could possibly help. I also just want to shout out to BEAS. They have a fabulous webpage that lists all the nutrition programs serving older adults. Definitely worth checking out. Next slide. Oh, thank you, Rachel. Okay. There's definite alignment with the State Plan on Aging, the Commission on Aging annual report, and the Alliance for Healthy Aging with all 5 strategies that were listed under community. I'm just going to talk briefly about 3 of them. Reduce geographic barriers to limit individuals' ability to access the preferred resources. Expanding availability of safe and accessible alternative travel pathways. This is in complete alignment with all the work that's being done in the state related to age-friendly community work. Increasing access to on-demand public transportation in rural communities. I'm so glad that this is part of this. This is also about access to opportunity. Things to note, the Commission on Aging, fingers crossed, will be getting some funding to do a transportation needs assessment and planning project that will be rolling out hopefully over the next year. It's I recommend the State Coordination Council for Community Transportation. They're leading a lot of work in this arena. I want to mention one of their projects is the New Hampshire Mobility Management Network. This began with braided DOT and DHHS managed CDC funds. Those CDC funds are going away if they're not gone already, but there are several other streams of federal funds that support transportation alternatives in our state. One of the goals of the Community Transportation Needs Assessment and Planning Project is to get all those folks who manage all those various funds in one room to discuss leveraging them in ways to best serve New Hampshire residents. There's a strategy talking about expanding resources to bolster caregivers' capacity with a focus on the parent-child dyad. I really don't want to take away from this. This is a really important objective or strategy, but I also want to say there's a critical need to expand resources for all caregivers. The majority of long-term services and supports is provided by unpaid caregivers. The financial, mental, and emotional drain is significant, and there's a great deal of evidence on poor health outcomes for these caregivers. It's my hope that this will be addressed as a priority strategy in the State Health Improvement Plan. And of course, we support lifelong learning. Moving on to the next slide. Okay, so health status. I've listed 4 of the 7 strategies. Under expanding community-based prevention programs, I just want to mention the community nursing programs really make a big difference for older adults. Course, expansion of homebound vaccinations and evidence-based programs. There's some wonderful ones out there, falls risk reduction programs, as well as chronic disease self-management. Expand closed door loop systems, no wrong door, no need to say anymore, right, Laura? spending a little time on conducting universal age appropriate screenings to identify early interventions. There's a great deal of intersection, especially around Alzheimer's disease. There's so much work to be done in this area. According to the Alzheimer's Association, there's approximately, as of 2020, there was approximately 26,000 people aged 65 plus living with Alzheimer's disease. This is expected to increase dramatically. Age is the greatest risk factor, with 1 in 10 people aged 65 and older and 1 in 3 people aged 80 and older experiencing dementia. There was a previously unsuccessful effort to bring CDC BOLD funding to New Hampshire. BOLD is building our largest dementia infrastructure. It was 100% public health funding. It supports risk reduction, early detection, diagnosis, caregiving, community care, clinical linkages, and public awareness. If this funding opportunity comes around again, which it might, I really hope we find a way to take advantage of it. Even if not, there's lots of work to be built on. Both Easter Seals and Mount Washington Valley have in recent years done dementia capable communities work. Alzheimer's Association, and there's even a homegrown dementia hub growing out of the Seacoast area. Last area, ensure well-trained workforce prepared to meet the cross-cultural needs of the communities. One of the key priorities of the commission is to grow the direct care workforce. There's some data on this slide that talks about the dire need for this to support long-term services and supports, and to Bobby's point earlier that she raised. We all know this to be true. And the representation is much needed in long-term care. Can you imagine having a primary language other than English and needing nursing facility care in New Hampshire? It'd be so isolating. Next, moving along. So I just wanted to make folks aware in the domain of social connectedness of a white paper that was done over the summer, social isolation among older adults in community settings in New Hampshire. It was funded by BEAS to the Partnership for Public Health. Thank you. There's a lot of good information in there that might help inform this particular domain. An outgrowth of that work is the wellness link that Laura mentioned. And finally, I want to put a plug in for Stay Connected New Hampshire. I noticed in the assessment area that you're looking into data concerning safety. When it comes to older adults, prevention of abuse, neglect, and exploitation is of great concern. BEAS and the Attorney General's Office does do work in this area, but I want to talk about the Stay Connected website is developed by the New Hampshire Financial Abuse Specialty Team. It's the FAST team. It's a multidisciplinary team, including people from state government, federal government, banking, and others. This work could also come under the first domain, under the support financial independence and self-sufficiency. I'm not really going to talk too much about, I'm not going to touch on the other 2 points. They're pretty self-evident. Moving on to almost the end here. I just thought I'd take a tiny iota of time to talk about 2 other initiatives that are in their early days. I'm sure that folks in this room know that the Community Health Institute was successful receiving a grant back in August from the National Network of Public Health Institutes and the Trust for Americans' Health to collaborate with both state level and community partners to develop age-friendly public health systems action plan for New Hampshire. It's meant to align with the age-friendly public health system's 6 C's framework for healthy aging and to enhance collaboration in New Hampshire to address health and well-being in New Hampshire's older adults. This work is a wonderful opportunity for SHIP and vice versa. SHIP could be a wonderful opportunity for this age-friendly public health systems. And I hope that each can leverage and benefit each other. And finally, just a little plug for some of the things with the commission. Annually, the commission produces a report. It's our chance to advise the governor and legislature on issues that related to aging. We had 4 overarching recommendations in our last report about strengthening systems of care for healthy aging, growing the direct care workforce, advancing age-friendly policy systems and environments, and developing a multi-sector plan for aging. That last one is an idea that's building the momentum now. The hope is to engage a wide swath of people to develop a vision for New Hampshire's future, rather than just the 26 members of the commission. States across the country are doing this, given the growing numbers of older adults and the increased longevity. People are seeing that there's just a need to modernize state government. They're developing these 10-year plans that set priorities, building off of other existing state plans like this SHIP, and other initiatives that, while also considering what else is needed. So, a hallmark of these plans is a governor directing the creation through an executive order, or the legislature doing the same through legislation. It's this first step that we're working on now with several other organizations, including the Alzheimer's Association, AARP, and the Alliance for Healthy Aging, just to name a few. Really, I mention this because SHIP will be integral to this work, and it'll be a foundational element. It echoes the framing that align with materials we plan on using for this multi-sector plan. Stanford Center for Longevity has their New Life map. I just recommend folks take a look. And I'm really sorry I took all the time.
That's okay. There was a lot to be said. So the good news is we don't have any public, so we don't have to do a public comment. So we still have a couple of minutes. And in fact, we will bump the SHIP implementation piece to the next meeting and do a little email with the council in between then. So that gives us 3 minutes. If anybody would like to ask a question, but before we do that, actually, I just want to give Polly the floor. Well, you were gonna ask a question anyway, so there we go. We're like on the same wavelength without knowing it.
Thank you, Joe. And thank you, Rebecca and Laura. This is great. And Joe and team for teeing this topic up. I missed most of the last meeting, so I wasn't part of the conversation to have it come forward. But those of you who are still left on the call may recognize that I've been a broken record in talking about older adults and the needs of older adults. And I really, really appreciate having the time for Laura and Rebecca to describe not only some of the work that is being done, needs that exist, and to make connections between what can appear to be a very disjointed set of individuals and groups working toward a common goal, but maybe not in a coordinated fashion. So the more coordination can be defined and described, I think the more perhaps we'll actually be able to make some change. So that's all I wanted to say. And thank you both for the short notice jumping into it.
Martha, did you want to add anything? I want to make sure that, so Martha and Polly were instrumental in helping us figure out the right folks to bring to this. So I want to make sure that if you have something that you wanted to add, you could do that.
The only thing I can say right off that really hit me was, the organizations that are really trying to provide those home care services. And so I would just encourage everyone we have another budget session coming up, every 2 years. We have a good base to build on with the system of care and the increased funding that we did receive to implement that. So I think, if we can all work together to continue to increase the funding and increase the services in the community in this next budget session, it could be a great success, really, for older adults in New Hampshire. So I think pulling people together is something that we really need to do in the next couple months and figure out what those priorities are and strategies are. So that's my only message. Let's work together on this.
Thanks, Martha. And I just want to note that, for those of us who've been doing this, I think what this presentation showed us is what Polly's been saying this whole time, which is that every aspect of the SHA and particularly the SHIP work has a almost unique feature around the older adult population. And I think, Rebecca, you sort of brought that forward in this too. So yes, we may have and we ran into this for almost every topic, right? We put it somewhere, but we knew it had reach to every other domain, but we had to create something that was 1D for a really 3D set of situations. But again, I think, what Polly keeps sort of reminding us is that every single one of those things that we talk about, when we think about it within the older adult population, and particularly the older adult population in New Hampshire, we have to really put some unique lenses on that. And I think you did a really good job of sort of bringing that forward. So I know we're 1 minute over time. Kim, did you want to say anything before we wrap up?
Thank you. Just really quickly, when you're talking about leveraging services for older folks or people with disabilities, I think municipalities should step up a little bit and play a greater role in that. And maybe funding can be tied to You know, if, for instance, my town wants to apply for any grants or any state funding, that there's a provision that the city itself needs to hold services of some kind, whether they're recreational programs or senior programs or library programs, where they can accept persons with dementia or persons with disabilities without having caregivers there, that staff are trained and can put aside this time to do it, because the workforce is one of the biggest problems we're seeing. We don't have the people to support those people, so they can't access those programs. So maybe that can be thought about when you're talking about leveraging these services. Thank you.
Love
Thanks,
that
Kim.
idea.
Great. Okay, so I apologize for a couple minutes over. We've got that implementation of the SHA SHIP next month. We want to do any reactions that folks might have to the public health block grant presentation. And I think we're going to try to bring someone forward to talk about the behavioral health system in New Hampshire, which obviously has ties to this as well. So I will send the meeting materials out so you all can spend a little bit more time with what we heard very quickly from the team, and we can figure out if we want to do it. Bobby had brought forward the last time that we haven't really done a deep dive on all the barriers. And so maybe that's something we just say we're going to do a barriers discussion instead of a topic one, which might be helpful. All right. Thanks, everybody. Thank you, Laura
Thank
and
you so
Rebecca for joining us today. And again, thanks for everybody for hanging in there.
So,